my name is Rick Stevens, and this is the Parkinson Network of Mount Diablo. Monthly, we have a Lunch and Learn seminar from which we invite an expert in the field related to Parkinson's or Parkinson's caregiving. Today, we have Dr. Stephanie Marquet. So basically, this is an hour presentation, the first 45 minutes or so of which are devoted to the presentation, and the last 15 or 20 minutes devoted to question and answers. And those questions come from you.
Right, can you all see my screen?
Yes.
Okay, perfect. Well, thank you. Welcome, everyone. And a special thanks to Beth and to Rick for inviting me and doing a tech check so that we could have this lunch and learn today. Thank you to the Parkinson's Network of Mount Diablo, doing lunch and learns and educating your community and being in community. It's really fantastic. Oh, I'm having a hard time getting to the next slide. Huh. Oh, there we go. There we go. Sorry about that. I think it's just a lag time.
Did you finish it?
Yeah.
Was it a good ending?
Oh,
I'm glad.
I'll just keep talking. I think I hear some chatter in the background, but
Right.
I know how that is. That's not a problem. So basically, I'll do an introduction to myself, but first I wanted to introduce the organization I work for. I work for Hospice East Bay. It is a nonprofit, community-based palliative care and hospice organization. And we provide care in Contra Costa, Solano, and Alameda County. It's an organization that I'm just so proud to be a part of and to represent today. I think I forgot to give you guys the title of my talk. Today, I'm going to be talking about hospice and palliative care, the similarities and the differences. And in the course of this, we're going to be talking about living with serious illness, advanced illness. This is my slide to introduce myself. This is me with my mom. She lives here in Berkeley, very close to me. I have been a practitioner, a healthcare practitioner, physician for over 25 years. The first 20 years of my career were with Kaiser in Oakland, Richmond, Alameda area. I started as an internist. I worked a lot in the hospital. I worked a lot in the ICU, and I saw a lot of suffering. I saw a lot of patients and families who had questions that had never been answered, even though they had been living with a specific disease for many, many years. And through that experience, I was really drawn to palliative care and got boarded in palliative care and became a hospice director at Kaiser. And then 5 years ago, decided to be an independent practitioner and have been working with Hospice East Bay now for about 2.5 years, basically with all through COVID. And I put this picture of me and my mom just to say that I understand that this issue, or for me, this issue is both professional and personal. My mom lives with some serious illnesses and it's not easy. But I know it's also a time of life that is rich with connection and meaning. So the goals of this talk for today, we're going to talk, I'm just going to kind of introduce the topic of talking about dying because it's not easy for everyone. And then I'm going to talk about palliative care, hospice, explore a little bit about when somebody might be appropriate for palliative care if they're interested. Talk about hospice, which is a Medicare benefit, and talk about when a person might be hospice appropriate. So as we begin, I just like to kind of pause and acknowledge that this is a tender topic. This can be a difficult topic for some to really kind of project ourselves into our futures. We know we all die. And yet, despite that knowledge, thinking about it, thinking about what's important to us as we come to the end of our life is not an easy journey for people to take. There's cultural issues, there's family issues, and our culture doesn't make it easy. There's not a lot of opportunities to sit in community and talk about what it's like to be living with a serious illness. So I like to think of today's talk as homework. Like anything, the more you prepare for it and the more you collect information and educate yourself, the better off you will be about making sure that the care that you are getting is the care that you want. So congratulations, this is your homework. And after this talk, please take a break, take a breath, do something nice for yourself, because these topics are difficult. All right, so we're going to talk about palliative care to start. And it's a beautiful word. I've always loved the word palliative care. And to palliate means to alleviate suffering. And specifically in medicine, palliative care refers to the practice of alleviating suffering for diseases for which there is no longer a cure. So what does that mean? What is palliative care compared to what I'll call traditional medicine? Traditional medicine, and we've all experienced it, and thank goodness for traditional medicine. It gives us quality of life. It can give us so much. But it does tend to focus on specific diseases and specific organs, and traditionally has not done a great job about really looking at the bigger picture of where are we going in our healthcare journey. Whereas palliative care prides itself absolutely on being very focused on the whole person, not just an organ system or a disease label. We like to look at the whole person. And we look at the person within the context of their family and community. We talk about how they are doing today. And we like to talk about treatments in terms of their benefits and their burdens. So what does it mean to be person-centered care? It means that we are life affirming. A chronic or classic misconception is that palliative care is hospice. And I hope by the end of this talk, you realize that palliative care is not hospice. Palliative care is very much about living as well as a person can live with the illnesses that they have. We frequently ask, a very common introduction question is, tell me what a good day looks like to you. Some people who are very disabled can absolutely have excellent quality of life and have lots to say about what a good day looks for them. Palliative care is values-based. We like to get to know a person and what's important to them. We look at the entire family. Now, some people are very private. For those of you who are very private and would not want your family involved, that's fine too. But a lot of people do want their families involved in their care, and palliative care likes to have family conferences frequently. It's culturally sensitive care, and we focus on quality of life. It's a constant topic. And we do absolutely talk about disease trajectories. So not just a disease name, but what is the trajectory of this disease over time? And we all know that living with chronic disease is very much about living with uncertainty. It's hard to know exactly what the future is going to bring. And that's a specific burden of living with serious illness. And it's one that we walk with a patient and family. So the current definition of palliative care is that it's a specialty. It's now recognized as a specialty by the American Board of Internal Medicine, and it's specialized care for people living with serious illness. This type of care is focused on providing patients with relief from the symptoms that they are experiencing, from whichever diagnosis they may have. The goal of palliative care is to improve quality of life for the patient and for their family. Usually palliative care is comprised of a team. It's a team approach that includes a doctor, someone like me, a nurse, and some other subspecialties, sometimes a pharmacist, and often spiritual care. And we add a layer of support to a patient's primary medical doctor, or in the case of Parkinson's, it could be a neurologist, to provide this extra layer of support along with the primary care physician. The key distinction with hospice is that palliative care can work in tandem with curative or traditional medicine. So palliative care can happen at any stage of the disease. It can happen in tandem with curative treatments. A classic example is chemotherapy. A lot of oncology offices now, and frankly, neurology offices now will have embedded some palliative care practitioners to work in tandem with their primary goals. All hospice is palliative care, meaning that hospice has the same goals of palliative care about well-being, person-centered care, but not all palliative care is hospice. Palliative care comes before hospice. So key differences, hospice is a Medicare funded program, meaning it is a defined benefit that comes with Medicare, and pretty much 100% of private insurance also provides 100% hospice coverage. Palliative care is very different. It's funded by insurance, but not all insurance has yet included it in their coverage. So a fair amount of palliative care is actually private pay. For hospice, a person has to qualify by two physicians saying that your time on this planet is likely to be 6 months or less. But in palliative care, there's no requirement about any specific prognosis. It can be much more upstream than hospice. Hospice comes to you, it comes to the patient, generally in your home or where you are living. Whereas palliative care is generally something that you have to go to. It primarily happens in the hospital. The most robust programs are in the hospital. They are also in clinics, and more and more in the past, it started right before COVID. There are some home-based programs, and in fact, Hospice East Bay, my organization, does have a home-based program. Hospice is considered care for the dying. Doesn't mean they're dying tomorrow, but they're dying most likely within 6 months. Whereas palliative care sees itself as a field that is caring for the living. So when might a person want to continue or consider palliative care? It's clearly this really great adjunct to traditional medicine. Why shouldn't everybody get it? It is specialized care. So it really comes into focus when a person is living with a fair amount of symptoms or a fair amount of disease burden, such that the usual treatments are starting to become more difficult to tolerate. So I like to say that when a person really clicks into the fact that their disease is progressing and they're having more symptoms, that might be a time to consider palliative care. If you're living with a serious illness, but then you have a new big problem, like a big stroke, or you had COVID and that has left you on oxygen or with long COVID. So now there's a series of illnesses that are piling on. That could be a time to think about palliative care. If you only have one problem, but it is progressing and you're finding that new frailty is showing up, weight loss, difficulty swallowing, lack of energy, sometimes falling, decreased independence, possibly skin breakdown from being in bed. Those are times that a person might want to consider palliative care. There's a question we hear a lot, and this is something that's been part of my practice forever, is people will say, well, doc, how come she's not the way she used to be? And I think we all know, like we know that about our cars, right? In some ways, our body is just a machine and it wears down like a clock or a car, and an old or a car that's been having a lot of problems. No, it's not going to be like a new car. And people generally kind of click into that reality and they're like, yeah, you know what? I'm in a different place now. Sometimes for palliative care, we call it the surprise question. Would you be surprised if this person or you yourself were actually to die in the next year or two? And if you say, no, you know what, I just wouldn't be surprised, that's a time to consider palliative care. So this is a graphic just to demonstrate what palliative care is and how it works with traditional medicine. So a person who is given a diagnosis and they're full bore. They're going to want to get every single treatment. They want to live as long as they can because it's possible. And medicine provides great care to people. So they're going along, they're trying new medicines. Maybe they get hospitalized once or twice. But then as things progress, their own body is aging, the disease is advancing. It's a terminal disease, one that is not able to be cured, of which there are thousands of diseases. That doesn't mean you're dying now, but we know that over the long term, this disease is terminal. As a person's symptoms are increasing and can't, be gone, it's not that this disease can get cured. As their symptoms are increasing, palliative care becomes consideration to help with explaining what's going on, planning for the future, getting your affairs in order, and really focusing on how can we help these symptoms. If it's shortness of breath, we got a lot we can do. If it's pain, there's a lot we can do. At a certain point with terminal illness, a doctor is going to say, you know what, I actually think now you are in the final chapter of your life. I think you might want to consider hospice because I think you have 6 months or less to live. And for some people, they say, you know what, if that's the case, I want to go to hospice. I want all my care focused on comfort. Now, I have to say, about half of Medicare beneficiaries die on hospice, and that means half don't. Hospice is not for everybody. It's a voluntary program, as is palliative care. It's really for folks who are very present in their disease and want to prepare for whatever is next, including if it's the end of their life. And the great thing about hospice is there's bereavement services. Bereavement care is a very important part. Even though we all die, we miss the people after they die. And bereavement is for the living who are left behind to have a chance to debrief and process their grief. Palliative care, when I'm talking about palliative care and hospice, I like to talk about this balance, this care balance of quality and quantity. We all wish we could have excellent quantity or excellent quality of life forever and ever, but we know that's just not the world we live in. When you're young and healthy, it's a no-brainer. Of course, you're going to want everything done to have as much time as you can. But as you get older and sicker, it starts to be more about quality. And it's really important I encourage everyone to think about, what does quality mean to you? Because it looks different for different people. It's amazing. This has actually been updated. I'm sorry, I have this older slide. This stat has proved true for a long, long time, that it's amazing how little the general population knows about end-of-life care and some of the key things that people should know about. Only 70% of people know even that hospice care, what it is, and that it's end-of-life care. A lot of people do not know about the POLST, the physician order for life-sustaining treatment. That's a whole nother presentation. I won't go into it, but if you don't know what a POLST is, please ask your doctor about it. Even advanced directives, the most basic place where people are write down, who they want to have speak for them if they can't speak for themselves. What kind of care would they want to avoid? Like, no, I would never want to go on dialysis. I absolutely want to go on dialysis. Even advanced care directives, only 1 out of 3 people have them completed in the over 65 population. So please, I encourage everybody, at a minimum, make sure you have an advanced directive. If this talk is coming at a bit of a surprise, or you were like, oh, palliative care, I've kind of heard of that, but I'm not sure what it is, you are not alone. A lot of people do not know what palliative care is. That's changing because it is fantastic care. It's very, like I'm saying, it's whole person care. But you're not alone if you don't know exactly what it is, or you've never even known anybody. Most people have known somebody who's died on hospice, but a lot of people don't have stories of friends and family getting palliative care in conjunction with their usual care. When people do learn about palliative care or have a firsthand experience, overwhelmingly positive. Because, like I was saying, what I'll call usual care is very disease specific and organ specific, and doesn't tend to take the bigger view of really, who are you? What's important to you? Let me help you plan for your future with whatever's coming down the road. So when they poll studies who with people who have had firsthand experience with palliative care, they all 92% say, this is fantastic. I wish I'd known about it sooner. I'm going to tell my friends and family. So palliative care, it's a new field. It's one of, in fact, I wonder if it is the newest field that is that was granted board specialization by the American Board of Internal Medicine. It was made a specialty in 2008. I boarded in, when did I board? In 2010. A lot of us who had been kind of practicing in a palliative care style had advocated for it to be its own specialty, really so that it could be reimbursed as part of insurance so that patients could have access to it. It is now rapidly growing. For those of you who are Kaiser members or Sutter members, I'll Get Your Care at John Muir, very robust palliative care programs, primarily in the hospital setting and in subspecialty clinics. It is a lot of big insurances are having a hard time building home care programs. So I wanted to touch just a little bit about the home care programs. They are showing up. It is primarily for folks who are homebound. So if you are able-bodied and going in to see your medical team, ask your doctors if this is something you're interested in. Ask your doctors what type of palliative care offerings are available for you. And if you are homebound or you have somebody who is homebound and might be interested, I would encourage you to call Hospice East Bay and check out our program. If you're Kaiser, also ask your docs. They have had fits and spurts about building home-based programs, but they are starting to become available. Just briefly, I'll touch on our program. We currently are serving about 45 patients, and that number changes, of course. We're board certified, which is an essential piece. If you're asking, there's always a lot of choice in healthcare, and you really want to know how well trained your practitioners are. And at Hospice East Bay, the physicians and nurses are all board certified in palliative care. We also have volunteers that work with our patients and access to most of our hospice resources. I'm going to shift to talk about hospice. Hospice is a much more established program, and I've been a hospice practitioner now for over 10 years, and I find it really incredibly satisfying work. Some people think of hospice as, oh, it's all about doom and gloom and dying. But I tell you, all my folks on hospice today, they're alive today, and we're focused on how can they have the best life that they can today, and how can they have a death that leaves themselves feeling that they've actualized what they've wanted to do and that their family is getting the support they need. So hospice is a Medicare benefit that was enacted in 1982, meaning there's no out-of-pocket expenses. It is part of your Medicare benefit. It is defined by Medicare as to be eligible, a person has to be in the last 6 months of their life. However, that's really hard to prognosticate. So everybody has stories of people who were given one prognosis. Your doc says, hey, you're going to die in a month. And 5 years later, they're saying, ha, joke's on my doc. Look at me, I'm doing great. And that's wonderful. I love those stories. I always love when somebody actually gets to graduate hospice, if that's what they wanted, because it's really hard to know when actually somebody's at the end of their life. Hospice is about keeping a person comfortable and generally staying out of the hospital. And hospice comes to you where you are. So palliative care, mostly you have to go to palliative care, whereas hospice comes to you at the end of your life. I wanted to just briefly talk about disease trajectories. This is a whole talk unto itself. But I think part of the reason it's hard to talk about dying is we all die in different ways. It's this one word that tries to encapsulate all the many different ways that a person dies. Some people are doing really well and then boom, they drop dead. We know that's less than 5% of the population. The red line is a classic cancer trajectory where a person can be doing very, very well. They get a diagnosis, they might get some treatments, But if it's an incurable cancer or the treatments are just not working, a person can have a very rapid decline towards the end of their life. And it seems like it's going really fast because the tumor has just taken over. The blue line is what I call organ failure. It's stuff like respiratory, lung diseases like emphysema, heart disease, congestive heart failure, where a person can have a series of illnesses that they recover from, but they never quite get back to the level where they were before. There's this kind of slow slope of decline after each of their acute problems. And eventually one of those problems, like a pneumonia or COVID or a fall with a hip fracture, a complicated surgery, a person just doesn't have the energy to get better and they are entering the end of their life. So it's kind of more this like sawtoothy up and down of getting worse, getting better, getting worse, getting better, never quite getting back to the way you were, say 5 years ago. The green line is a dementia decline. Some of the neurological conditions are in this category. Parkinson's is not quite like this. The Parkinson's baseline function can stay a bit higher, but that generally the baseline of health can get quite low. But then a person can survive quite a length of time, even with a very low functional status and cognitive status. It's called the dwindles. We call it the dwindles, where a person has this very low baseline. They're not doing great, but they're not dying. And that it can be very hard to tell that a person is actually in that final phase until they really stop eating and drinking. So when might a person be ready for hospice? That's a common question we hear. And again, this is not based on your disease. Many diseases are considered terminal diseases like Alzheimer's, but you live with Alzheimer's for 20 years, or congestive heart failure. You can live with that for, 20 years as well. So it's really about your prognosis. It's about the accumulation of complications that are leading to decline. So for something like a dementia or Alzheimer's, a person might want to think about hospice when they're no longer walking, when they're bedbound, when they're no longer able to control their bowel or bladder, possibly only have a few words left. There could be weight loss. That tends to not be reversible for a lot of the neurological conditions. Once a person is losing weight unintentionally, that can be a sign of an irreversible decline starting. When the skin starts to break down, that's also a sign that the body doesn't quite have the energy to heal itself. Infections, complications, and certainly complications that are requiring hospital level of care that are starting to snowball, 2 or 3 hospitalizations in 6 months, that's a red flag that something is going on, and a person may want to consider hospice. These are also just more examples: heart failure, COPD. When might a person with those diagnoses consider hospice? It could be that they're now needing oxygen all the time. Maybe you didn't need it 5 years ago, 2 years ago, you needed it for when you went to Disneyland and had to walk, but now you actually need it all the time. If a person is short of breath at rest, you used to be short of breath just if you had to run for the bus, then you started to get short of breath after you walked a full block, but now you're short of breath even just sitting in a chair. That's a sign that your body does not have the energy even to breathe. Some people come to where they're just living in a chair or the bed. And again, this sleeping more, eating less is a sign that a person is coming to the end of their life. For cancer, it's when the disease is widespread, advancing rapidly with or without treatments, and a person's body is getting really tired. I can't see the top of my slide here. I think this is again more to kind of just clarify what hospice is. That hospice is a program to serve people with 6 months or less of life and who no longer want to seek curative efforts against their disease. I often tell folks, unfortunately, that a person is hospice eligible. Sometimes people wish they had more time. but no matter what they do, the treatments just are not working. And again, I know these are hard things to talk about and to hear. On hospice, the focus is comfort. We generally don't do labs or workups, and we come to you instead of you going to the ER or hospital. The beautiful thing is we're open about it, we're transparent, we talk about it. A lot of folks at the end of their life, they really just want to talk about it. They don't want to do it alone. They're in it, they're experiencing it, and they want to share it. And hospice is able to support patients and families as they go through this and offer bereavement to family after the death. What's covered? All sorts of things. So whereas the palliative care is not a benefit that's well defined, the hospice benefit, because it is well defined, includes a doctor, a nurse, a social worker, spiritual support, home health aides, bereavement services, 24-hour telephonic support, medical equipment, medications, only the ones related to your hospice diagnosis. And again, that it's a covered benefit, meaning there's no out-of-pocket expenses for patients and families, unless they want something above and beyond what hospice can do. Like some people want a really fancy bed. Well, hospice may not be able to cover that. Or like a fancy, these portable oxygen devices, there's some things that hospice is not able to provide. And hospice comes to the person wherever they live. It can be in your home or it might be in a care facility. This slide is a little bit repetitive. These are, again, the healthcare part of hospice is covered by Medicare. But what is not covered, and some people are surprised to learn this, that hospice does not cover the care you will need, meaning like the bedside care. Say you're bedbound and you need a lot of personal care. That's considered attendant care or personal care, and that's provided by the family. And hospice is also not a place you go to. Hospice comes to you wherever you live. So some families, the older we get and the older our family gets, sometimes people are not able to die in their own home because their caregivers are not able to provide that care. So some folks choose to go to a board-and care or assisted living or wherever makes the most sense for them. But hospice comes to you wherever you are. Sorry, this is again about the same slide about what's covered, and to emphasize that there's no co-pays. So again, I wanted to, I love this organization I work for. Hospice East Bay has been around for 40 years. It's a nonprofit hospice and palliative care organization. That means everything we do kind of gets returned back to the community, back to the patients we serve. We provide great care. Not all hospice agencies are the same, I'll tell you that. Again, I've been doing this a long time. I have a lot of friends working for different hospices, and you want to make sure that the hospice agency that you choose or that your family or friends choose has the highest ratings and provides the best resources, meaning, are they going to answer their phone in the middle of the night? Are they going to be able to dispatch a nurse to you when you need it? You want to make sure you go with a good agency. And I'm happy to say that Hospice East Bay is an organization I'm very, very proud to work for. We also have a ton of volunteers. Some of you guys may know the volunteers, again, because we've been in Contra Costa and Solano County for over 40 years. Some of you guys may know the Bruns House, which is a small hospice hospital. There's only 6 in California. We're one of them. To go to Bruns House, a person has to qualify for inpatient care because of their symptoms, meaning something is really not, like their comfort level is not where they want it to be. And sometimes we have to use things like IVs and more sophisticated care. Some of you may know Hospice East Bay because of our thrift shops. We do great work there, and it's all tax deductible. I think we all know the benefits of nonprofits versus profit, and I have nothing against for-profit hospices. They do great work. There's many, many really good hospice for-profit agencies. I personally enjoy working for nonprofits because all of the money that that comes in is redistributed. We do birthday presents for our patients. We have a visiting pet program. We have 6 music therapists on staff. We have an amazing bereavement department because that's all work that we feel It's the details that matter to a person and family. And know that those volunteers and extra services are available on palliative care as well. I'm going to end my talk there. I find that generally this topic of living with serious illness generates a lot of questions. So I'm happy to hear whatever questions you have and answer them. And thank you so much. It's a pleasure to speak to folks. I'd like to say as well, I don't know about all of you guys with COVID, but COVID took all the energy for so long. It's really nice to be able to kind of go back to some of the essential topics that we had to put on pause because it was all COVID all the time. So I'm happy to be back out in the community and providing education on hospice and palliative care.
Well, thank you very much, Dr. Marquet. So if you'll stop sharing your screen unless you need to go back to it for some reason,
Okay.
we'll then open it up to questions. So if you want to ask a question, you can either at the bottom of your screen under reactions, raise your hand there, there's a button, or simply unmute yourself and ask your question. So this is the part for what we call audience participation, folks. Okay, Janice, you have your...
Yes, thank you very much. I'm still a little fuzzy about a couple things, and one is, would you say that a primary care physician for both hospice and palliative care is the gateway, or is it through the social worker in the neurology clinic, or who is the best person to talk about these things with in the medical system?
Okay, great question. Great question. So if I've understood the question, it's about how do you get to palliative care or hospice?
Right.
Is that the question?
I mean, you need.
I always say start with your doctor.
Okay.
Now, some people have a ton of doctors. Go with the doctor that you feel most connected to. If you have Parkinson's or a different disease process, and you have a primary doctor who's managing that disease, I think that would be the best person to say, I heard about palliative care. Is there a palliative care clinic that I can go to that you know about? Some of them are embedded in it. Like, I know the Kaiser system best, so I'll speak to that. In oncology, it's an automatic referral to palliative care. They will always offer, would you like to see a palliative care specialist as we're talking about your cancer treatments? But if nobody has ever mentioned palliative care to you, then I would ask your doctor to say, I heard about this thing called palliative care. Does your clinic offer it? And then to ask specifically what is included in that palliative care offering. Because it's not a defined benefit, sometimes it's just a social worker. And they do great work too, but they may just have a program that's about completing healthcare directives and documents. Whereas some palliative care clinics have a full team, somebody like me, a nurse, a chaplain, and a social worker to do much more intensive symptom management and talking through like which treatments are going to give you the most benefit versus potential harm. And then for hospice, it's actually a bit different. Hospice is a self-referral program. Okay. So if you look online and you check hospice, you look up hospice in my zip code in the Greater Bay Area, there's about 30 different hospice agencies that you have to choose from. In any of them, you can actually pick up the phone, call them and say, I think I am hospice eligible and I would like to enroll with hospice. Hospice will then reach out to your doctor. They'll ask you more information. They would reach out to your doctor to confirm that indeed your doctor would agree that you're at the end of your life. So instead of self-referring, most people come to hospice through their physician. Okay. And I would say this kind of brings up a good point about a lot of doctors, we know this from questionnaire after questionnaire, a lot of academic studies have asked doctors, are you good at talking to your patients when you think they are at the end of their life? And like, they do terribly. They know they are bad at it. They're not trained in medical school, and often they're not trained in the course of their practice about how to be honest with patients. However, in terms of, more and more patients are becoming advocates for themselves. They're self-advocating for a different kind of care. And if you let your doctor know that you're interested in knowing more about what's happening to you and how to plan for this, for your future, because you think your health is declining and you want to know more, you want to talk about it, then I find most doctors do a good job because they have a good heart. They're coming at it because they really do want what's best for you. And if you let them know, what's best for me is more information and potentially not getting these toxic treatments if I'm not going to get better.
Right.
The conversation really switches. So I would, with your next appointment, introduce it if you're interested, to say you're somebody who would want more information about what to expect as this disease progresses.
So to be open and direct about it. And
Yes.
it just,
It
not
kind
wait
of
for
gives
the
them permission.
okay. The other question I had was in terms of hospice care. I was under the illusion that people from hospice physically helped a patient who needed it in their home. And apparently that's not quite what you said. You said that.
Right. The most common misconception I come across is around caregiving.
Mhm.
Hospice is the medical portion of your care when you are facing the end of life. So a nurse will definitely come to your home, but he or she will stay between 30 minutes and an hour, do an assessment, call the doctor, see what treatments need to change. But then they leave. And hospice also includes some home health aides who will come and provide, say, a bed bath or a nice shampoo. But they'll come once, twice a week, perhaps. And everything in between is provided by the family. So the kind of the daily care needs, the meal preparation, the feeding, the personal care, the changing of the bed sheets, that is not part of hospice.
Okay. Well, I'm glad you clarified that for me.
Yeah, I sure wish it were. We all do, because it's hard and expensive.
Yeah, but do if you employ someone to help with the caregiving, do they interact with the hospice people as well?
We do a lot of caregiver training, a lot. A lot of what we do is teaching how to care for a body that is quite frail and delicate, just like caring for a baby.
Mhm.
The nurses in the hospital show you how to hold the baby. We do the same. We do a lot of training of caregivers and family on how to care for someone.
Okay, thank you.
Yeah.
We have one question that's come in from on our chat. Maybe it relates to what Janice was asking about hospice, but this is about palliative care. If you opt for palliative care, what kind of practitioners would you see? And what is a typical visit?
Great question. So because palliative care is not a Medicare benefit, it doesn't come with a standard, meaning there are many different flavors of palliative care teams. When I started, our palliative care team was just a doctor and a nurse. That's how Kaiser came into the field. But as we were building our program, I know there were programs that were offering just a social worker who was focused more on doing kind of advanced care planning documents. So I can't guarantee who you will see. I would encourage a person to ask. So I know Hospice East Bay because that's who I work with. So we are a team of physicians, a case manager nurse, a nurse practitioner, a social worker, and we have access to our hospice chaplains who come and work in our palliative care setting. So that's who we are, and that's kind of the standard. In the hospital is where you'll most likely get a full team like that. But in clinics, it really depends on the specific insurance you have and what the specific hospital system is offering. And what a typical visit will look like, it generally starts with a family meeting. We like to meet not one-on-one with the patient. We like to meet with the person and whoever they feel is their main kind of caretaker or healthcare proxy. And it tends to start with information. You know, who are you? What have you been through? We request all your medical records so that we kind of know what you have been through. And then generally start by saying, what is it that you're hoping to get out of this encounter? And often it's about symptoms. It's that, well, my pain is poorly managed, and my doctor's not quite sure how to manage my pain. That's a common one. Another common one is trying to think through, am I ready for hospice or not?
All right. Yes, go ahead, Janice.
Yeah, I have another question. Last fall, I watched a webinar about neuropalliative care. Do you know if there's anything like that in the Bay Area?
Yeah, there certainly is. At UCSF, their entire palliative care group is based in the ALS clinic.
Okay.
You can get palliative care at UCSF for any condition, but where their offices started was in the ALS clinic. So it really is, so neuropalliative care is really just palliative care for folks with neurological conditions.
Right.
So their entire staff will have had just more experience and possibly additional training in caring for folks with neurodegenerative diseases. So yes, I mean, I wouldn't say that I'm specifically a neuropalliative care practitioner, but do I care for folks with neurodegenerative diseases? Absolutely.
Yeah, it seems that the goals and everything are similar to what you mentioned.
The same. It's just so each subspecialty, like nephrology, kidney care, is very interested in palliative care. So they'll say that they have nepropalliative care, but really it means that they're palliative care practitioners that are focusing on a subset of people who are living with kidney disease, or in the case of the webinar you went to, with neurological diseases. And it would be great. You know, Parkinson's is a specific disease, has a specific set of consequences as a person advances in their disease.
Yeah.
So speaking to your neurologist would be a great idea.
Yeah, because I think, I mean, it is increasing neurological diseases, specifically,
Sure is.
especially Parkinson's and others. But
yes, very true.
So this person that was giving the webinar felt that it was an up and coming a subspecialty.
That's right. That's right. Yeah, it's a new field, and like any new field, it kind of starts broad. But I agree, as it's becoming more impactful, we're finding that kind of specialization within the broad field can be helpful.
Yeah, but Kaiser doesn't have a neuropalliative program at this point, does it?
Well, so there's a gentleman, Bowen Wong. He works out of, Dr. Wong, he works out of Oakland, and he's a neurologist who is double boarded in palliative care. So we're starting to see more subspecialists who feel that they have the specialty training, or just by experience they're drawn to the work. So there's really a range out there, and unfortunately I hate to say it, but it's a little bit. I encourage patients to advocate for themselves, to ask about it, to say, I am interested really in an approach that talks about my values. I want to know about disease trajectory. I want to know about options as I go through this disease process. And to me, that sounds like palliative care. Where would you direct me? And it is hard, you know, doctors, sometimes they want to give you 10 minutes and not 30, but doesn't mean you can't ask for a 30-minute appointment.
Yeah, and you're so right about patients not ever having that discussion with their doctors for whatever reason, discomfort on both sides or whatever. But and they just keep going on, not realizing that there is some help if they just ask.
Yeah. Palliative care does a lot of what I'd call pattern recognition. You know, you can go to a doctor's appointment and it's all chit chat. And, hey, you're doing well.
Yeah.
Keep going with your meds. I'll see you in 3 months. Whereas a different discussion could be, hello, how are you? Tell me how things have changed for you since I last saw you. Even if it's subtle, you know, has anything changed? It's like, oh, well, you're gaining weight. I'm really happy to hear that. Or, oh, you're losing weight. That might be something we want to pay attention to. Let me tell you that when a patient is losing weight over 6 months, that's really a sign that their body is no longer kind of processing all that protein. And you're going to be susceptible to more complications.
Yeah, and I think also asking the caregiver, because so many times the focus is on the patient, and the caregiver really doesn't get a chance to chime in until the very end, and then you say something. But I think including the caregiver in the dialogue with the physician is important.
Sure, I 100% agree. Yeah.
All right,
And it
so
doesn't
we're
mean-
open to other questions as well. Are there any questions that folks have, or? Well, I have one that's based on what you had said earlier, Dr. Marquet, and it's, what is values-based palliative care? That really struck me. I wondered, what does that mean?
Yeah, that's a really great question, because it's something that we hold both in hospice and palliative care as a key tenet. You may have heard there's a new movement in advanced care planning with these advanced care health documents, is this idea of goal-directed care, that instead of just talking about what treatments are available, first talk about what your goals are, and what goals are realistic. So in talking about what a person's goals are, often it does get to be about values, meaning, what does a good day look like to me? Or what does leading a good life mean to me? Some people are just fine, say, having artificial nutrition. They feel that that is absolutely something that makes sense to them, and it's something they'd want for themselves. Whereas some other folks say, no, I don't want that. Eating food and tasting the food in my mouth and being able to feed myself is something that is very important to me, and it's something I've always wanted to do. And if I can't do that, please don't feed me by artificial means. That is what I would call values-directed palliative care, meaning taking the time to find out what type of care makes sense to you. What are your goals? It can also involve spiritual beliefs. You know, a lot of us have faith traditions that come up, especially as a person starts to face the end of their life. There are religious beliefs that come into play. and talking about them can be very important.
So I assume that this also dovetails into culturally sensitive care.
Yeah, absolutely. In addition to religious beliefs, culture just means like the water we swim in. I might be from a family that where people don't speak out of turn. So I might be the youngest child of a large family, but I have some key information. But I'm the youngest child, and I'm not going to speak up unless I'm invited to do so. So understanding cultural differences, and then creating environments where everyone can speak up, because we know, as Janice was saying, that often caregivers have essential information that is really going to be helpful for us all to know. So we work hard to, in culturally sensitive ways, find mechanisms to have everyone's voice be heard, so we really get a full sense of what's going on. That's one example. There's gender issues. Women can approach, or like a mothering, people who have wanted to like be the caretaker for everyone around them. When they face the end of their life, it can really be very difficult, because they are no longer able to care for others and they have to accept help. So if you see someone and you have to think of these things to be like, I think this person is resisting our care because it's so against who they think they are. They see themselves as being the caregiver, and this is so hard for them to accept our care. I'm going to ask, hey, I'm noticing it seems hard for you to accept our care. This is what your family wants to do for you. This is what we're all here to help you with. Let's talk about that. What is this like for you?
So
that's an example.
The implication is that there's a strong need for helping the caregivers in their own process.
Yes. So as we all get older and we live with more serious diseases, the role of caretaker is, and COVID has made us, there's been a crisis in caregiver support. It's an enormous job, and there's not a lot of focus on it. And we talk about caregiver respite. Well, what does that mean? What are the burdens of being a caregiver, and how does one support a caregiver so that they can in turn be the best caretaker that they want to be? So yes, caregiver support is actually kind of at the origin of hospice and palliative care. When we say we don't focus just on the person, we focus on the community around them. What we're saying is we want to include the caregiver as essential to the patient.
I have a question that came in on the chat, which is, would you know if Stanford University has a palliative care group?
Oh, they do. They have a great one. But you just have to ask for it. Sometimes there's a waiting list, but ask for it. Yes, Stanford has a fantastic palliative care group, and they're both in the inpatient setting and they are in the subspecialty clinics. I know they're in the oncology clinic. Beyond that, I'm not quite sure the specifics. So I would ask, and then, if you're asking, be prepared for a secondary question. They'll say, oh, why are you interested? And so you may say, well, I'm thinking about the end of my life, or I'm thinking about where this disease is going. And I want to start, I want to really think about what decisions I may be having to make in the future. I want to think about them early. And I'd like to do that with a palliative care practitioner.
Well, Dr. Marquet, that brings us to about the end of our hour. It's 1:03, and we'd like to try to end it about on time. So I wanted to remind people that This entire presentation will be up on our YouTube channel within 48 hours, so that if you want to watch part or all of it, you can find information. We will email it to you. If you subscribe to our YouTube channel, you'll get an automatic notification. But to all of you who stayed through the presentation and to Dr. Marquet, I want to extend a very great thank you.
Thank you. Remember, this was your homework. Everybody gets an A+ today. And now take a break. These are heavy topics. If anybody has questions, feel free. Our Hospice East Bay, the phone numbers are all over the internet. Call. We have a fantastic intake department that's happy to answer any questions you may have.
And we'll put some of that information in the YouTube description as well. Okay, thank you all.
All right.
And
Thank you,
until our
everybody.
next-
Have a nice afternoon.
Yes,
Thank you.
bye-bye.